because on the rexus, so that the rexus occurs even before the fluid comes out, this intumescent cataract. But here you could just phacoaspirate or just use an IA. It's a very soft cataract, and needless to say, polishing of the anterior posterior chamber is mandated in these kind of cases, and then you inject your lens and you're bailed yourself out. Now this is a significantly hard white cataract, and it looks as if the rexus is quite fibrous. Sometimes in very dense fibrosis, a femtolaser passage is not very comfortable, but this fibrosis was not that intense. The only thing, you cannot just bunch it up and lift it. It's not free floating, so you need to use a cystitome to remove it. But as I'm just trying to inject viscoelastic, I see that small tag which is there, which it is important to remove it, make it an entirely smooth rexus, because these could become the weak points for a rexus extension. Then it is about, of course, in these total cataracts, there is no nuclear fragmentation which happens because it's a totally white opaque cataract, and you have to do your manual approach, and then it just becomes a routine surgery. But getting a consistent rexus in all of these difficult cases is what which makes a phacoemulsification a consistent and a repeatable success, which may not really happen in a if you are on a manual mode. Now this was a case which started off, which was a fairly normal dilating pupil, but it was a little smaller in size. You have the ability, when the pupil does not accept it, you could go on to the pupil maximized button. You can press that, which will give you the maximal pupil size, but you can cheat the machine and use your cursors to enlarge the rexus so that it comes within 100 micron of the iris margin, because it will not impact the iris of cause meiosis because of the prostaglandin release if that 100 micron space is there. And then with that, the decent 5 millimeter rexus could be worked out. And then you have to just bunch up the rexus, because you need to be sure that there are no tissue adhesions and you have got a complete rexus. In a small eye and a shallow eye, you need to do very gentle hydro and ensure you keep decompressing and then rotate the nucleus. After clearing the little superficial epinucleus and cortex, make a small trench and use that as a fulcrum to split it into 2 halves. And then these are cases which you would have to have used an iris hoop or anything more complex, as was all discussed in the whole session. But as you can see here with the femtocataract platform, although the pupil size is coming down, the challenging movements of a rexus or softening or segmentation of the nucleus is also completely done, that you are able to actually treat these cases as a routine normal case, and you are able to get done with it. Of course, you need to be ensure that you remove the viscoelastic in front and behind the IOL, do all those important things, retract the iris to ensure that you have removed all the cortex. Those steps are there. Now this is a polar cataract. Here multiple cylinders are being created. This is on a different laser platform. Multiple cylinders are created, and you could ensure that there is energy could be lowered if you want to have less of cavitation bubbles. And the advantage of having multiple cylinders is it would create multiple epinuclear cushions along the way, so that the surgery done anteriorly will have no impact on the weak posterior capsule. It was a free floating rexus which comes on, gentle hydrodelineation is done and decompression of the bag. So now all that is going to be done is separating these pies which have been created by the segmentation, and just chew it up with a phaco so that one level of the tire is eaten up, and keep going layer by layer. But all along your posterior capsule is not impacted by any of the intracapsular pressure changes which are occurring with the phacoemulsification. As you can see, the parameters are also kept at a fairly low level. And finally, all that you have is just one epinucleus cushion, and that also very easily gets folded up, and you find that a polar cataract is not at all a challenging case if you are able to do it on a femtocataract platform, unless an ASOCT has told you there's a PC dehiscence, which of course then it brings in its own quota of challenges in a case. And then here, this was a coaxial IA, so we have used aspiration port to get the sub-incisional cortex, because you don't want at any point of time anterior chamber shallow, and even that can trigger off PCR at the most unexpected moment. So this was a case which happened well. Now this is again another case which is actually a small pupil and a dense, a thick nucleus which is there. which again is something which I'm going back to explain it to you. I did the pupil maximized, but still the pupil size was only 4.5. So then I've used manual cursors. But one thing which I did miss out was that there was a through and through opening which occurred when doing the astigmatic keratotomy, which was evident during laser delivery. But when I started the surgery, I could see that the fluid was coming out through this perforated bone. It absolutely mandates, it's a very rarest of rare complications, that you need to suture up that small perforated linear incision, because otherwise with a small pupil and a fluid egress, it would actually become nearly impossible to do an easy surgery. But again, because of the femto dissection and the fragmentation, even that amount of smallness of pupil and fluid coming out of the perforated wound, we still could complete it as a normal, near routine normal case, and thankfully it did not leave any astigmatic impact. However, a BCL had to be placed. Now this was a case where there was an ICL in the patient's eye altogether, so offsets were increased so that it could cut the optical device which was placed on front of the anterior capsule. It was one of those earlier cases where I've increased the vertical spot space into, but on late we do not do that. You can see as I'm doing with the ICL, there is a cut which has happened on the ICL too by the femto laser pass. So you are left in doubt, and those areas of bubbles which tell us that could be that those areas are uncut areas. So it's better to use your cystitome and tease out the rexus, which is nearly cut in most parts, and anyway it's a template. Even the areas which are not cut, you can tease it out. You can just go on the flip mode, because invariably these anterior subcapsular cataracts are very soft cataracts, and then the surgery gets done and the IOL is placed. Now this was a case of an intact, so you need to downsize the rexus a little so that you are able to visualize the rexus within the intact segment. That is what was done, but even then on the table when starting the surgery, the rexus was not visible, it was covered by the area of intact, so you needed to gently tease it out. There was always a doubt throughout the case whether there was any area of rexus extension, because the overlying intacts could have obstructed the in any way the laser pass. I'm not clear on that. And then it is just a question of fragmenting, but every step you need to be careful, because the overlying intacts is sort of obscuring your vision, because you're not able to clearly visualize your rexus margin. Even teasing out the cortex has to be done very carefully so that you are on the exact plane, and then the IOL is placed and done. And this was a case of RK, but there were not multiple RK incisions, thankfully. But these are all hypertrophic scars, and you could be clear that these areas, the rexus might not get cut completely. That is one challenge which you have. If you have multiple RK incisions, actually it is in mandates that we make your incision more scleral than corneal. But as there were fewer incisions, the incisions were made between the two RK incisions, and you need to remember that these RK incisions could give way at any point of time. You could ensure that the parameters on the phacoemulsification is not very high, there is not too much of pressure in the anterior chamber, enough viscoelastic is placed. But again, incidentally, much to our luck, this was a very soft cataract, and with all the grid softening which happens, it was like just carouseling out of the entire nuclear fragment. But you can see there's a rexus extension, sub-incisionary. Thankfully, the surgery was quite uncomplicated, but that was an area which has given way because of the scar, the hypertrophic scar of the RK, and thus the surgery got done. So I think these are different ways you are able to tweak small parameters and do very well with the femtocataract in some of these moderately challenging cases. Thank you.